Welcome, and thank you for joining us for today's event, Take Heart, the Milestone Findings of the Framingham Heart Study. My name is Gabe Bolio, and I'm a member of the Career Programs team here in the Office of Alumni Relations. Today's webinar is sponsored by the Boston University Alumni Association and is offered to our 346,000 alumni around the globe. Over 200 members of the BU community have registered to join us today, hailing from 21 different states and several countries. I also want to acknowledge the large number of alumni, students, faculty, and staff joining us who work in the medical community. Please accept our sincere gratitude for your tireless work and leadership throughout this pandemic. Thank you. Today's presentation is being recorded and will soon be available for on-demand viewing on the Alumni Association website. Our speakers have reserved time at the end of the presentation to answer your questions. You can submit questions throughout the presentation by typing them into the Q&A box, which you can find by mousing over the bottom of your Zoom screen to reveal the toolbar and then selecting Q&A. It is now my pleasure to introduce Dr. Karen Antman. Dr. Antman is an internationally recognized expert on breast cancer, mesotheliomas, and sarcomas. She is provost of the medical campus and has served as dean of Boston University School of Medicine since 2005. Dr. Antman previously served as Deputy Director for Translational and Clinical Sciences at the National Cancer Institute of the National Institutes of Health, and before that, as Wu Professor of Medicine and Pharmacology and Director of the Herbert Irving Comprehensive Cancer Center at Columbia University College of Physicians and Surgeons, where she also co-directed the Cancer Care Service Line at New York Presbyterian Hospital. Based on our group's translational research, Dr. Antman developed now standard regimens for the treatment of sarcomas and mesotheliomas, as well as regimens for breast cancer and supportive care of patients receiving chemotherapy. She has written extensively about impediments to clinical research on cancer, and she's testified before Congress on the need for federal research dollars. She has written more than 300 journal papers and edited 5 textbooks and monographs with many multiple editions. And this truncated biography only begins to scratch the surface. Dean Antman, it is a pleasure to have you with us today. And now I turn the floor over to you.
Thank you very much. On behalf of Boston University Alumni Association, I also want to thank you for joining us for our program here today. I'd like to welcome you to the webinar to learn more about the ongoing Milestone research that has been taking place in Framingham since 1948. The Framingham Heart Study is an important collaboration between Boston University and the National Heart, Lung, and Blood Institute that, in addition to identifying risk factors which contribute to heart disease, also performs cutting-edge heart, brain, bone, and sleep research. Today, we're very fortunate to hear from the principal investigator and director of the study, Dr. Vasan Ramachandran, and his fellow investigators. Dr. Ramachandran is Professor of Medicine and Epidemiology at Boston University School of Medicine and School of Public Health. He serves as the chief of the section on preventive medicine and epidemiology in the Department of Medicine. His research interests include heart failure, echocardiography, high blood pressure, risk prediction, and medical policy. Dr. Ramachandran has had an exceptional career. He's one of the top cited researchers in the world. He has published on a wide range of cardiology-related topics in the New England Journal of Medicine, the Journal of the American Medical Association, the British Medical Journal, et cetera, et cetera. He's received many awards internationally. We're very proud at BU of this long-standing partnership with the National Heart, Lung, and Blood Institute and the world-class research that has emerged from this study. Please join me in welcoming our speakers, Dr. Ramachandran.
Thank you, Dr. Antman. Good afternoon, friends. And if you're on the West Coast, good morning. It's my pleasure to actually introduce 2 of my colleagues. It's always an honor and a privilege to be on Zoom with colleagues who are smarter than yourself. I'll introduce Dr. Michelle Long. She's an assistant professor in the section of gastroenterology within the Department of Medicine. Michelle has worked with the Framingham Heart Study for almost close to a decade. She has an illustrious career with funding from the NIH, the Doris Duke Foundation, and multiple awards, including a Research Mentoring Award from the Department of Medicine and a Gilead Scholar Award. She also is the Director of Research and the Director of the division that deals with non-alcoholic fatty liver disease within the section of gastroenterology in the Department of Medicine. Next, I'll introduce Dr. Vanessa Xanthakis. She's an assistant professor of medicine in the Department of Medicine and also has an appointment in the School of Public Health in the Department of Biostatistics. Vanessa is a biostatistician by training and a clinical investigator strongly committed to clinical research. She's worked with the Framingham Heart Study for close to 15 years, and she's the director of research in the section of preventive medicine within the Department of Medicine, and she directs postdoctoral training program, also a research program training the medical residents in the Department of Medicine. So I want to thank both Vanessa and Michelle, my colleagues, for being on. And I also want to thank Gabe for organizing this and to all of you for making the time to listen to us. And now, if I may, I will share my screen and talk a little bit about the Framingham Heart Study. We've been speaking to the alumni in the past. I believe I spoke to you all about 4 years ago. So I want to talk a little bit about what has Framingham been up to since we last spoke. Since some of our alumni may be new, I'll introduce you to the Framingham Heart Study, which I refer to as a public health collaboratory. In other words, it's a laboratory with which all of us collaborate and all of you can as well. The Framingham Heart Study began in 1948 and has 6 different cohorts. And the red arrows point out through the 3 transgenerational cohorts, the grandchildren, the parents, and the children. And the gray box outlines 2 of our minority groups, the Omni cohorts that were recruited subsequently to increase diversity within the Framingham Heart Study. Just to begin with, to tell you what exactly the Framingham Heart Study has done in a nutshell, to put this talk in context, the Framingham Heart Study began because in 1948, heart disease was a major scourge in the United States of America. And people wanted to understand why people get heart disease. And in its first 20 years, Framingham Heart Study defined the major risk factors that caused heart disease: smoking, high blood pressure, high blood sugar, high cholesterol, being excess weight. In its next 30 years, we addressed the issue of not only heart disease, but stroke as well. We identified other disorders of the heart, including irregular beating of the heart, referred to as atrial fibrillation. And beyond risk factors, Framingham focused on how do we predict disease before it occurs. And that deals with the notion of subclinical disease, cardiac ultrasound, or stress testing. And Framingham study was one of the first tests to implement both in 1978. And then we also leveraged the transgenerational cohort to understand the familial transmission of disease. In the last 20 years, we have built further upon the notion of risk factors, subclinical disease, to now talk about how can we marry the advances in genetics, the completion of the Human Genome Project, with the extensive measurements that we do in Framingham. And we advanced our measurements to include CT scans, MRI scans, and also characterization of small molecules. And I shall talk about this briefly. And also the notion of social networks. So I want to cover 5 sets of updates over the next 7 minutes or so. And these refer to the notion of precision phenotyping, perturbation epidemiology, genetic results, machine learning, and COVID-19 research. And I'll give you an example, one example of each. So the notion of precision phenotyping refers to the notion where we not only make measurements on the human body, but we go deeper down to the tissue level and begin to characterize our circulating proteins and the small molecules. And what this does is that what you see on the right-hand side, we're able to make molecular measurements at the level of the genome, what we call as the omics toolbox, which is how the genome manifests itself, and biological pathways. And we marry this to what you see on the left side. That's the assortment of traits that we've been measuring for decades, some based on clinical measurements, some based on history, and some based on the laboratory. And our extensive repertoire of imaging studies, some of which will be described by Dr. Long. So here's an example of how we have used Framingham to characterize the circulating proteins in your body. Now, if we take a drop of blood in your body and we could measure thousands of proteins on this using high throughput technology referred to as DNA aptamer technology. And in this particular publication, we asked the question that we know that there are some lifestyle factors that either prevent heart disease or predispose to heart disease. Now, how does that happen? How does it work that our habits result in disease? So this is what we did. And we looked at 3 exemplary habits. One is alcohol consumption, and we are aware that moderate alcohol consumption can protect against heart disease, referred to as the French paradox, because the French drink wine and live longer. Smoking, that's a risk factor known for close to about 60 years. And physical activity. And in this particular study, when we did correlational analyses, we identified 60 proteins in the blood that were associated with the habit of drinking alcoholic beverages. 30 proteins, levels of which changed because of smoking, and 5 proteins that were changed, levels of which were changed due to physical activity. The reason this is important is you can imagine that not only do we understand the biology of how lifestyle factors can result in protein changes and risk of disease, but we have identified the fingerprints about how we can actually use these proteins for development of newer drugs or identifying better targets to target. Moving on to the second highlight, and this is what we talk about as perturbation epidemiology. And the reason we call it perturbation is in systems biology language, standard epidemiology has always measured things in a standardized fashion. When people are at a state of rest, in a fasting state. More recently, it has become very clear that how we respond to perturbations helps us identify measures of vulnerability, risk, and resilience. And one such test is what we call as the cardiopulmonary exercise testing. And just in a recent examination, our entire 3rd generation and the sister minority group, we completed cardiopulmonary exercise testing, which means you sit and exercise on a bicycle ergometer for close to about 10 minutes. And we completed about 3,000 plus tests. Now that's the largest study on a population-wide basis. And we generated over 150 physiological variables. Most importantly, we measured some of the molecules, small molecules that circulate in your blood before you exercise and at the peak of the short burst of exercise. And here's an example of one of the papers that we published, where we wanted to understand again, acute bouts of exercise. How do they prevent heart disease? And here's the schema where we have the blood sampling at the beginning of exercise, the peak of exercise. And here we have these small molecules we can measure, some of them using mass spectrometry techniques. Some of them are more fatty particles or lipids, some free fatty acids, some polar metabolites. And what we found after the bout of exercise is when you have an acute bout of exercise, some of the things that prevent diabetes or insulin resistance, they go down. The markers of fat breakdown increase. Markers that reflect a substance called nitric oxide that's good for our blood vessels, they tend to grow up. And markers of browning of fat, they tend to increase. So right over here on the right-hand side corner, you can see why exercise may be beneficial to us, because it can prevent diabetes, it can break down body fat and promote the good kind of fat, and it improves healthy vessels. In other words, the exercise changes in the metabolome identify how we promote heart health. It's little wonder that this particular publication actually made it to the New York Times last year as the omics of exercise. Going on to the next third update that I want to share with you, and this is the notion of return of genetic results. Now, Framingham is an example of a cohort where we have done whole genome sequencing on the vast majority of our participants. And when you do this kind of whole genome sequencing, you identify risk variants, some of which cause cancers like breast cancer or colon cancer. Others cause forms of thickening of the heart muscle like cardiomyopathy. And what had not been done is a way of giving back the results to the participants. So this is the major project that we started in partnership with the Mass General, Brigham, and the Broad Institute. And we call it the genomes to people, because we are giving back the genomes to the people. And this involves are consenting our participants, identifying the genetic variants, mapping it against the American College of Medical Genetic Variants, and then a phone call with a genetic counselor. Now, these are research grade tests, so we need to do clinical confirmation. That's called clear testing. And then we share it with the clinical provider, and then we refer the participant to a specialist. So this is a major investigation in progress, where we also want to see what happens when we return the results of variants that people harbor to them in terms of the health behavior, in terms of the psychosocial stress, and in terms of other follow-up costs associated with healthcare. Moving on to the fourth update that I want to share with you. And this is a notion about how Framingham is really not your grandmother's study. Framingham really is using state-of-the-art techniques in terms of analyzing the piles of human data that we have. And I'll show you an example of what we call as radiomics. Now, we all know that if you take a CT scan of the chest, you can measure the deposition of calcium on the heart vessel walls, referred to as coronary calcium. What we can do using computer algorithms and deep learning is we can actually do what is called feature extraction. We can look at the texture, we can look at the distribution. A lot of things go above and beyond what's a simple calcium score. So if when you use this, you generate a thing which you call as the radiomic score. And if you divide it into tertiles, low, middle, and high levels of a radiomic score, and you look at how many people, once you do this and you follow them up, develop heart attacks or strokes, you find that when the radiomic score is high, it's about a 15-fold increased risk of developing heart disease or stroke or dying as compared to the lowermost. And this radiomic score does much better than the simple calcium score. In other words, if you apply machine learning, in this case, deep learning, to existing images, we are able to extract information and actually apply them to predict risk and to actually intervene. The last part is to show that Framingham has been up to over the last year or so, and that's COVID-19 research. So Framingham is one of the cohorts that's part of a large national NIH-funded consortium called the Cohort of Cohorts, Collaboration for COVID-19 Research, or C4R as we fondly call it. And this is a diverse group, geographically and geospatially spread, of nearly 50,000 individuals. And what you can see over here at the bottom in the red box is that Framingham is a big player over here. We actually contribute a chunk of participants, nearly about 7,000 participants to this important consortium. And we'll be answering questions which are of interest to this audience and to the country. Why do people get COVID-19, severe infections, and the related disparities? Who are the people who get long COVID or long-term complications of COVID-19? And how does the occurrence of a pandemic alter your baseline health trajectories? And how do the social determinants of health play into the heart, lung, and brain health trajectories? This involves questionnaires, involves ascertainment of events, and dried blood spots for obtaining levels of antibodies against COVID-19. To summarize my talk, the Framingham cohorts are conducting precision phenotyping. We have introduced what I describe as perturbation epidemiology or response to stressors. We return genetic results, including whole genome sequence, in a very thoughtful and humane way. We use novel analytical techniques, including machine learning, and Framingham has been participating in COVID-19 research over the last year. Next slide shows you the depth and breadth of Framingham Heart Study research, where our collaborators are all over the country. So I'm hoping that some of you will think of participating in Framingham-related research activities and collaborations. I want to thank you for your attention, and with this, I'll hand over to my colleague, Michelle Long. Michelle, please take it away from here.
Great. Thank you so much. Just going to share my screen. All right, great. So thank you so much for inviting me to this talk. I'm going to talk about the work that we're doing studying liver fat and fibrosis in the Framingham Heart Study. So you may wonder, what is a gastroenterologist doing in Framingham Heart Study? Well, I mostly study non-alcoholic fatty liver disease, which is a metabolic type of liver disease that is associated with diabetes, metabolic syndrome, and obesity. And some call it the metabolic equivalent, the liver equivalent of the metabolic syndrome. And I often get asked, well, I have too much fat in my liver, and is that bad for me? What does that mean? Well, we know that about 1 out of 4 people will have too much fat in their liver, and in some subpopulations, it's even more. What we do know now is that it's more than just liver fat that's important. It's really the scar tissue or fibrosis. So some people with liver fat will develop inflammation in the liver, and that will lead to scar tissue. But we don't really know why some people will have scar tissue and others will not. We think that liver fat contributes to cardiovascular disease by increasing systemic inflammation and the release of different inflammatory markers. And we know that those that have liver scarring, in addition to liver fat, have a higher risk of both liver-related outcomes like cirrhosis and liver cancer, and also all-cause death. But very little is known about how liver scarring may affect cardiovascular death. Up until recently, liver scarring has been difficult to diagnose. And if you have 2 people, you might ask, well, who of these people here has liver scarring if they both have fatty liver? Liver fat can be, you can tell if someone has liver fat based on typical liver imaging, like an ultrasound or a CAT scan. And in fact, we have done a lot of work in the Framingham Heart Study previously using CAT scans to define and quantify how much fat is in the liver. But what about scarring? Is there a way that you can tell easily who has scar tissue or not? And what does that mean if you have too much scar tissue in the liver? So one of the reasons why I'm so excited about fatty liver disease is that there's just more questions than there are answers. So one of the project that I will talk to you about is a project that we had done in the most recent 3rd generation and minority cohort exam that was completed in 2019. And some of the questions we wanted to ask was, how common is liver scarring in the community? And is liver scarring worse for metabolic health? And can we easily identify people who have liver scarring? Previously, to the best of our knowledge, we think that about 1/4 of people will have too much fat in their liver, and about 1/4 of them will have this inflammation, or what we call NASH. And some of those people will have fibrosis as well, or scarring, and we don't really know how many. And most of the other groups that have looked at this have really focused on people and patients that are referred into the hospital or who already have liver complications from their fatty liver disease. So we really don't know what it looks like in the community. So what we did was we used something called transient elastography. And this is basically a modified ultrasound probe. And you can see here in the picture, the participant will lay down on a table and the technician will will find a good spot, which is between the rib spaces. And you place the probe in between the rib spaces and you push a button. And when you push the button, it actually, you feel like a tapping sensation over the liver. And that tap actually induces a mechanical shear wave, and that shear wave has to propagate through the liver tissue. And if the liver is very stiff, then the shear wave goes through, takes a long time to go through, and the number will be higher. And that will relate to how stiff the liver is, which relates to how much scar tissue or fibrosis is in the liver. Also, while that wave is going through the liver, the device also measures how bright the liver is, so we can quantify how much fat is in the liver. So this is a novel technology that was FDA approved in 2015, but had yet to ever been applied to a large population in the United States. So we were very excited to have the opportunity to do this in Framingham. So what we did was we offered this as a part of the core research exam. When participants came in, they underwent this test. It only takes about 5 to 10 minutes. I'll present to you some of the results. So how common is liver scarring? We found that 9% of participants have scarring in the liver. And this was really interesting. It's about the same prevalence of diabetes. So it is, fairly common, given that pretty much all of these participants, with a few exceptions, really had no idea that they had anything going on in their liver until we did this test. Well, is liver scarring worse for metabolic health? We were able to look at the association between having liver scarring and various cardiometabolic risk factors. And we found that those that had liver scarring had 2.5 times the odds of having diabetes, and also almost 2 times the odds of having obesity, and 1.5 times the odds of having metabolic syndrome, high blood pressure, or low good cholesterol. That's your HDL cholesterol. And this was really even after we accounted for the amount of fat in your liver, which we already have known and have shown in prior Framingham studies to be associated with metabolic disease. So even after accounting for how much liver fat you have and your body weight and other cardiometabolic diseases, we found that just having scar tissue in your liver was associated with an increased prevalence of various cardiometabolic diseases, in particular diabetes. And then we asked the question, are there groups that have a higher risk of liver scarring? And we found that if you took just participants that had obesity, 16% of them had increased liver scarring in their liver. And if you looked at participants with diabetes, almost a third or quarter to a third had increased liver scarring, which shows us that these may be important groups to look at when we're considering whether or not someone is at higher risk of having liver-related diseases. But there's still many questions to ask. So some of these questions we hope to continue to ask as a part of future projects. What are the risk factors for liver scarring? Does liver scarring worsen your future cardiovascular health? What about the genetics of liver scarring, and is it heritable? So we have an ongoing project in the older age offspring cohort, and we will look at the relatedness of liver scarring. And then can we predict who will develop liver scarring? And then how does different health habits like diet or physical activity relate to scar tissue in the liver? Of course, I want to thank the participants for allowing us to do this important work, and the people that have mentored me along the way and supported this project, and my funding agencies. Thank you.
Thank you, Michelle. Let me just share my screen. So good afternoon, everyone. It has been a true privilege to be a Framingham Heart Study investigator, and it's a pleasure to talk today about cardiovascular health, which has been the focus of my research for the past 8 years. In 2010, the American Heart Association set the strategic impact goal to lower cardiovascular disease mortality by 20% and increase the cardiovascular health by 20% by the year 2020. And to achieve that goal, they created the Life Simple 7, also known as the Cardiovascular Health Score, which includes 7 behaviors and risk factors, such as smoking status, body mass index, physical activity, diet, cholesterol, blood pressure, and glucose. They defined 3 categories: poor, intermediate, and ideal health, based on established thresholds, and assigned points on each one of those 7 metrics based on the categories that I mentioned before. So the CVH score ranges from 0, defining poor cardiovascular health, to 14, defining ideal cardiovascular health. Now, there have been tens, if not hundreds, of reports published in the literature emphasizing the favorable role of a high CVH score with regards to risk of disease. And of course, the Framingham Heart Study, with the richness of the data, has been at the forefront and has played a prominent role. Our group has evaluated the relations of the CVH with multiple biomarkers of endothelial dysfunction and cardiac stress, with components of subclinical disease, indices of cardiac remodeling, dementia, cognitive function, multiple cardiometabolic diseases, cardiovascular disease, and all-cause mortality, just to name a few. The common theme among these multiple reports is that the higher the CVH score, the lower your risk of disease. And for those in the audience who are familiar with the Kaplan-Meier curves, you can clearly see the separation in the curves among the 3 groups. Now, having participants who attended routine examinations, they're able to provide us with serial measurements on hundreds of variables. So we're able to describe 20-year trends in the CVH score. And we observed that the proportion of participants with ideal CVH has decreased over the last 20 years, starting with a low percentage of 8.5% having ideal CVH during the years 91 to 95, down to 5.8% during the years 2005, 2008. That decrease is mostly due to the decline in the proportion of people with an ideal blood pressure, cholesterol, glucose, and body mass index. Now, a striking observation was that people who increased their CVH score during that 20-year period were at a higher risk of cardiovascular disease and mortality compared to those who started with a low CVH score and maintained it at a low level after 20 years. So that made us first think of the importance of achieving an ideal cardiovascular health very early on in life, and also made us dig deeper in the data and observe that for each 5-year time period that a person maintains their CVH score at an intermediate or ideal category during midlife, their risk of developing cardiometabolic diseases, cardiovascular disease, and all-cause mortality is much lower. So all these findings have been published in high-impact peer-reviewed journals, which is great for all of us who are involved in every day in cardiovascular disease research. But what does CVH really mean to the community? The clinical implication of what we call the CVH score is not really evident. So most people understand that having a CVH score close to 0 translates in higher CVD risk. But it's not easy to understand how much a person needs to improve their CVH score in order to avoid the development of cardiovascular disease. So in collaboration with the American Heart Association, we created what we call a vascular age calculator. It takes the CVH score, it converts it into the vascular age using an algorithm, and then every person is able to compare their vascular age to the chronological age. Based on that result, if the vascular age is higher than the chronological age, they need to consult a physician on lifestyle changes and risk factor management. that vascular age is smaller than the chronological age, that means that they're on the right track and they should maintain the current lifestyle-related behaviors. Now, this calculator is a tool that's easy to use, and primary care physicians can more easily, I should say, communicate risk of cardiovascular disease to their patient. There are a couple of calculators now that are currently being used, but there are a few limitations with regards to the use of physical activity and diet information. And this is where we come in, where our group at the Framingham, with other cohorts as well, comes in. And this is the knowledge that we will add to the literature. This is what the vascular age calculator will look like. As you can see, it's very easy to plug in the numbers for each metric, and the algorithm gives you the value of your vascular age, or otherwise called the heart age. So this is work in progress, and it will be published in a couple of months, but we're still considered an unhealthy population. So the question that comes in mind is that how exactly and when exactly does the non-ideal cardiovascular health contribute to cardiovascular disease risk over time? Is there a progressive worsening of the risk profile over the years? Or are the antecedents of the cardiovascular disease, for example, subclinical disease, already established in young adulthood upon exposure to suboptimal cardiovascular health? A couple of months ago, we published a paper and we alluded to the concept of life course health development, or LHD. And in summary, there are multiple health trajectories. But the most important thing to know is that we are able to intervene and change the course of our health trajectory. Cardiovascular disease is not something that just develops during midlife or even later in life. It's something that starts very early on and it develops during the life course. Now, maintaining and achieving ideal CVH is not as easy, and it does require a multi-sectoral approach. We need to ensure that everyone has access to healthcare and equity and education. So there is a long latency between non-ideal CVH and cardiovascular disease onset, and that provides us with a unique opportunity to screen, counsel, and promote health efforts. The combination of the high burden of risk factors that we see among children and the gaps that exist between guidelines and pediatric practices offers additional areas of improvement, such as educating future parents and counseling current parents, establishing programs in early childhood education on the importance of physical activity and healthy diet, and also focus on the power of community and establish spark discussions on prevention of disease. And this picture serves as the take-home message of my talk. Today, we desperately need an improved surveillance of cardiovascular health among children and adolescents. And I will leave you with our family's small effort to increase the levels of physical activity in the hopes of reducing the burden of cardiovascular disease nationwide. Thank you so much for your attention.
Thank you, Vanessa. And that brings us to the last but not the least part of the session today, where we'll talk about the Boston University connections to another study, which is the newest cohort study in the NHLBI portfolio. So it gives me a lot of humility and also a lot of pride at the same time to acknowledge that not only is Boston University leading the oldest epidemiological study of heart disease in the country, but we are also leading the youngest. And this is a study we refer to as the rural cohort study, rural being an acronym for risk underlying rural areas longitudinal study. So we've all heard the story that your zip code is more important than your genetic code. And what does that really mean? And why do we say that? So where does America live, and does it really matter? And the answer to the question depends upon time. If you have to go back a century, the population of the United States was close to about 100 million, and half the country was urban and half the country was rural. Rural being approximately defined as areas which have a population size less than 50,000. Then you fast forward 100 years and you find that there's progressive urbanization of the country, with 80% of the population, a little bit over 300 million now, living in the urban areas. And the rural green bar you can see is flat, about 20%. What's important to note is that the vast majority of the population, the urban population, occupies about 3% of the land of the country. Whereas the 60 million people, the 20%, occupy 97% of our land. And it's intuitive to think of it this way because rural areas are our breadbasket. They are the areas where we have our great rivers, our military installations, our mineral wealth. And for a large part of our existence, if we look at health of urban and rural areas, the rural areas were healthier, greener, vaster, agricultural base of our economy. And then something happened. Something happened in the last 60 years or so, that death rates, or mortality rates as we call it, in the rural areas started climbing up. Whereas urban mortality, often due to heart disease, cancer, and other causes, started plummeting. And during this time, it also became clear that the rural areas in the South fared the worst. If you look at the map of the United States and you look at the Southeast, here's where you have the hypertension belt, the stroke belt, the diabetes belt, the obesity belt. And it's commonly believed when you have this co-clustering of risk factors that perhaps it's got to do with the mutually reinforcing impact of these risk factors. They have common drivers and presence of one exacerbates another. And epidemiologists sometimes refer to this as syndemics or co-clustering epidemics. What's clear to us is that this status quo, where some of these areas are really at very high risk, is really not acceptable. So the common explanations, why do we have this rural mortality or morbidity penalty, as sometimes people refer to it? And here are some common explanations: that the rural areas are older, the education levels are lower, and they face greater food insecurity. Rural areas have often in recent times faced economic challenges, and you could judge it from different metrics shown on this slide, and the rural areas seem to have fared worse. They also have a higher burden of certain behavioral risk factors that Vanessa referred to, including smoking and physical inactivity. But it's important to remember what Chimamanda Adichie said, the danger of a single simple story. The reason behind the greater burden of disease and death rates in the rural areas, especially in the Southeast, is probably very complex. And that's what a group of us did, starting from Boston University, where we lead the study, to a partnership or a collaboration with 16 different universities in the country. That we have begun investigating the patterns and the onset of disease, how they vary with rural residents, and whether context rather than geography or the people may play a role over here. So rural is a study where we focus on 10 counties in the Mississippi Delta and the Southern Appalachia. And these 10 counties are across 4 states: Alabama, Mississippi, Louisiana, and Kentucky. And what you see in green are the counties that are very high risk. When I say high risk, to give you a sense of magnitude, the risk is about 4 times that of Massachusetts. These are very high risk in terms of heart disease and stroke mortality. But when we looked at the geospatial variation of heart disease and stroke mortality rates, we were surprised to find that within the same rural landscape, equally economically challenged and matched for race, were also low-risk counties. These were the unicorns. So that's the notion I brought forth, that perhaps the story here is a little bit more complex than the usual explanations of perhaps it's due to poverty or perhaps it's due to race. So what rural does is we are planning to recruit approximately 5,000 people, a little bit less than that, people in the age group 25 to 64 years. We will oversample the blacks. And we have an ecologically paired design that refers to the notion of higher risk and low risk counties so that we can compare. And one of the critical hallmarks of rural is community collaboration. These are rural counties. These are distant. So the people will not come into a brick and mortar building like the Framingham Heart Study. So you partner with the community, you learn and listen to them, and you take the science to the people, which is the science on wheels, or the framing of on wheels approach, if you will. And this is what we have done over the last year or so. We have built our own customized 53-foot trailer, which has got multiple parts. It's got the state-of-the-art CT scanner, the fastest CT scanner in the country. It's got an echo machine, cardiac ultrasound machine that uses AI. It's got a mobile lab that can function in this setting. It's got interview rooms and reception, and we can park this mobile examination unit in the rural counties and invite the people into our science. And here's an example. It's a real picture of how the rural mobile examination unit looks. And it's going to be coming to Alabama this month, in the middle of this month. And this is a panoramic view of actually how the 53-foot trailer looks, with the CT scan being located over here, the reception area being over here, and the mobile laboratory being over here. So the science on wheels approach is how we deal with the digital gap, with the physical divide, and other divides that exist between rural and urban America. In terms of phenotyping, we do on this mobile examination unit everything that we have been doing in Framingham. We just do it at the community doorstep. This includes questionnaires. This includes measurements of pictures of the heart, of the stiffness of the vessels, CT scans of the lung, of the body fat distribution, spirometry, which measures your lung function test. But importantly enough, we also do a few other things. Because of the digital divide, rural participants get a smartphone, they get a Fitbit, and we pair them so that we can monitor the behavioral risk factors. We also are looking at drinking water, for example, because this is also the heavy metal belt. So rural is a multi-dimensional, multi-level study, which uses a transdisciplinary team to really understand the basis of the high rates of disease in the rural Southeast. So here are the highlights of rural in this particular slide summarized for you. We focus on groups of people who are at higher risk using a paired design, a science on wheels approach with a focus and emphasis on community engagement and collaboration. Hoping rural is the doorway to future implementation science. So I want to make the point that rural is not just a Boston University study or a consortium study. It could be as much your study, depending upon your interest in learning more about it, collaborating, and listening to what we are doing. The rural website is at the bottom of this slide, and my email is there at the very bottom of this slide in case you have further questions. I really appreciate your patience in bearing through our long conversations, and we would like to spend the last 13 minutes answering your questions. My job here is to actually help my smarter colleagues answer those questions. So I'll begin with looking at the chat. And I think there's one open question, or I think Michelle has already answered that question on liver fibrosis.
Mhm.
Thank you. So we'll open it up for questions if there are additional questions that people have. I think Mindy is asking, will the slides be available for the heart presentation? We can make the slides available. We'll make a link available to this webinar itself. We can do that. Thank you, Mindy, for your interest, and happy to oblige and facilitate. Other questions? Elizabeth Minesian is asking, is this presentation recorded? Vanessa or Michelle, I'll pass on the questions to you.
Yes.
Sorry, Michelle, go ahead.
Yes, the presentation is recorded and you will receive information about how to access that after the presentation is over.
I think Gabe mentioned that he will be sending the link for the recording to everyone who registered for the event.
Yeah, thank you. Girish is asking, what is the process of enrolling in the program? So there are two parts to this question. This could refer to Framingham, this could refer to rural. So I'll hand over the Framingham part to Vanessa or Michelle, one of you.
Michelle, you can go ahead.
You know, we are always interested in identifying collaborators. You can find our email through BU. The CTSI website should have access to all of our research profiles and our email and contact information there if you're interested in collaborating from a research standpoint. The Framingham Heart Study is currently not enrolling new participants at this time. We're focusing on retaining the participants that we have and have been following over years to come.
Thank you.
I think I would encourage everyone who may have a similar question to visit the Framingham Heart Study website. So it's framinghamheartstudy.org. There's a plethora of information from what data are available to the publications that are now in the literature. And there's a lot of information on the investigators and everything that's been going on during the past few years. So, but as always, feel free to contact us. We can provide you with our email addresses as well.
Thank you. Regarding the enrollment in the rural cohort study, we use a probability sample with a sampling frame. And if the notion is of enrolling in terms of collaboration, my email at the bottom of the slide, it's vasan@bu.edu. Happy to discuss that further. Eileen McIntyre is asking, how can we support your work? Maybe Vanessa, you go first and then Michelle goes, then I can go.
Sure, so that's a wonderful question. And I think it's very important to first off acknowledge the work of the participants. You know, without the data of whom none of this would be possible. And the second part is to spread the word. So spread the word of the importance of maintaining a healthy lifestyle and spread the word of what has been happening at the Framingham Heart Study and how everyone from participants to staff to investigators to senior faculty members to the executive committee, how everyone has been working hard to increase and to fill in those knowledge gaps that exist in science. So spread the word, and always happy to join, to have everyone, new investigators join our efforts. So thank you so much for that question.
Michelle, how can this support your work?
Yeah, absolutely. I echo what Vanessa said. And, you know, I think many of the studies that we do at Framingham, pretty much the whole study relies on external funding, generally from the NIH. And, you know, we are always interested in ensuring that we continue to be doing innovative work and be supported by the funding agencies. So, you know, on a big kind of level, supporting congressmen and legislation that people that are supportive of medical research and understand that this is, you know, should be a priority. That is all, you know, supportive of the Framingham Heart Study.
Thank you, Michelle. And to answer the same question for rural, I think support takes multiple forms. I think the most valuable support you have is that of your time and your energy. So spread the word around and collaborate or guide people towards either the Framingham Heart Study program or the Rural Heart Study program. We also appreciate donations made through the alumni office. Anna Spuzak is asking, cholesterol lowering drugs do lower cholesterol. Do you live longer? Michelle?
You know, I think that there's a lot of potential benefits of being on cholesterol lowering drugs. And this is definitely something that we study in Framingham. And I think that there have been some studies that have shown improvements in lifespan for people that are on cholesterol lowering drugs.
Thank you, Michelle. There's a question from Harshad Sangvi. If they found fatty liver on CT scan with no history of alcohol, what should be done?
Well, that's a great question. So the real question is, is there inflammation there in the liver, and is there scar tissue in the liver? So the next step clinically is really to answer those questions. You could, FibroScan is available by a lot of providers, so you can order a test like that and see if there's increased liver scarring, which might suggest that the person who has the fatty liver may be at increased risk of liver-related disease. Or if imaging isn't available, there are other blood-based tests that you can do, something called the NAFLD fibrosis score, for example, or the fibrosis score. But really, it's talk to your doctor, find out what, if they can perform one of these risk stratification tools to see if you are at increased risk for liver-related disease.
Thank you, Michelle. Susan D is asking, are you working with the rural family medicine programs? Susan, we have partnerships with the rural programs in the 4 states and in the counties, and usually it's more with the federally qualified health centers. We are expanding our partnership with the local family medicine programs as well. Becky Carr asks, are you looking at the impact, interrelationship of inflammation in conjunction with any of these studies? Michelle and then Vanessa.
Yes, we are very interested in understanding how inflammation may impact liver scarring. So that is part of our studies.
And the studies that we have been involved in, absolutely, we definitely try to include markers of inflammation, either as adjustment variables or more recently in performing mediation analysis, trying to understand whether inflammation mediates some of the associations with the main exposures of interest that we are evaluating. Yes.
And in the rural cohort study, understanding the burden of rural inflammation and its association with both behaviors, risk factors, subclinical and clinical disease is at the heart of it. I think Girish is sharing 2 facts about the existence of an Indian Circle for Caring USA and launching of a lifestyle program, and has offered to connect. Thank you, Girish. Elizabeth Minesian asks, how you identify rural by population and space. Elizabeth, we use the definition of the OMB, Office of Management and Business, and that defines 2 kinds of rural areas. The micropolitan rural areas have a population size between 10,000 and 50,000, and the non-core are much smaller ones, that's less than 10,000, and the 10 rural counties of rural include a combination of both micropolitan as well as non-core counties. Bob, I think Harshad is asking, how do you diagnose scarring with fatty liver? Question CT scan.
Right. The CT scans are really good at identifying liver fat, but not scarring unless it's really, really end-stage liver disease, cirrhosis, and then you can sometimes see nodular looking liver. So in Framingham, we are using this liver stiffness, which relates to liver scarring.
Thanks, Michelle. The next question is also for you from Monica Nalkar. At what point do you recommend a liver scan for people with diabetes or the metabolic syndrome?
That's a really good question, and there's a lot of debate about that in the literature right now. If you ask the American Diabetes Association, they recommend that everyone with diabetes gets a liver scan, but the liver disease societies don't recommend that right now. So there's a lot of debate, and the real question is, how will it change your management clinically? There are a lot of ongoing clinical trials looking for new drugs to potentially reverse liver scarring.
Thank you, Michelle, again. And I think we have completed answering most of the questions. If there's anything we have left unanswered, we've got about a minute more for questions. Otherwise, I'll hand it back to Gabe. And I do want to personally appreciate all the people who took out time to listen to us, and all the excitement and the interest by the questions is palpable. So we really appreciate your engagement with us.
Great. This was fascinating. Many thanks, Vasan, Michelle, Vanessa, for your wonderful presentations today and for sharing your research with us this afternoon. And Dean Ammon, thank you so much for joining us at the beginning of the presentation. It was great to have you here. Would also like to thank you for joining us today. And as always, special thanks to our donors for supporting BU and for supporting programs like this. Before I let you go, I want to make sure you know about BU Connects, which is the Alumni Association's newest platform exclusively for BU alumni, students, faculty, and staff that brings Terriers together for networking on a global scale. The platform offers a networking directory, a place for jobs and internships, mentoring, and most importantly, groups for industry and affinity networking, including our Life Sciences, Health, and Medicine network. You can join BU Connects at buconnects.com. And any final words from the panelists?
Thank you, thank you, thank you. Vanessa and Michelle?
Yes.
Thank you very much for your attention. It was a pleasure being a part of this webinar.
Yes, thank you so much, and for your questions. And I hope that we hear from you some more.
Well, it was so wonderful having you all here today. Thanks again for joining us, and we hope to see you all at a future BU event.
Look forward to this. Thank you.